Hi, folks. My name's Mitch Stripling. I'm an emergency manager in Brooklyn, and this is my Apocalypse Prep COVID-19 rundown. And tonight, what I want to talk about are these reopening plans, particularly in Georgia, and why I think they're going to have a much harsher impact on people and communities of color around the country. So let's let's dig into that. Technical difficulties aside, a lot of what the early coverage of this said was that COVID-19 and viruses were equal opportunity, right? This was the great equalizer. Well, what we know from a public health standpoint is that a virus, maybe pure in nature, is an equal opportunity killer, but a disease in this country is not. The diseases are going to kill in ways that we see in public health and that we know are unequal, and that they are based on sort of structures of power that are baked into how this country operates. And we are already seeing that in COVID-19, and we have been for a while. In Mississippi, Black folks make up 38% of the population, 56% of coronavirus infections, and 72% of deaths. Black residents in Milwaukee County were half of its COVID cases, but 81% of its deaths. In Louisiana, they were 70% of the deaths, but only 33% of the population. Tragically, I could do this all day. This is not new information. We saw this at the beginning of this virus. And then what we saw, as the Brookings institutions reported this week, that gradually the virus began to not be as centered in communities of color, and it sort of broadened its place. The headline there was it moved into sort of Trump-supporting suburbs. And then we sort of hit this plateau, and now we're at a place where some governors, notably in Georgia, but in other states, are talking about reopening. And the tragedy of that, the worry that I have, is that the cases haven't gone anywhere. We have plateaued. They are simmering under the surface. And when they spike, and they will spike when these reopening plans happen, they're going to hit communities of color worse. And let's talk about why. That's really what I want to unpack, is why that's going to happen and what we can do about it. And what I want to say at the top is this is not about bias. This is not anybody acting like racist in some buffoonish way, even in the state house of Georgia, which is my home state, right? This is not, as it's being reported in the media, that they're flinging the doors wide open for everybody to come sort of rushing back to life. There's a series of steps that Georgia's following. And the Department of Labor is looking at things like unemployment benefits and building, the economy back gradually. They're trying to do it in a thoughtful way, but still, it's too early and it's going to cause deaths. So let's talk about why. So when you see this in the media, usually you hear a couple of things, right? You talk about why people of color have underlying health conditions, the living and working conditions lead to more infections, and they don't have as good access to health care. And a lot of this data is based on the confluence, the intersection of race and poverty. So what I hear a lot from folks is that, well, why do you make this all about race when in fact this is really about class and the access to care that people have? And the fact is that in America, when you talk about poverty, you have to talk about race because they're so interlinked. And I'm not the first person to say that, obviously. I'm like the last person. Many people have said this much better, even in terms of the COVID-19 outbreak. Aletha Maybank in her op-ed, and then an Oprah special, Jamel Bowie this week in the New York Times. But it hits me, and I had to say something about it because it's something that is the most tragic part of the structure of this country, both that it happens and that it will get more people killed, and also that it is so invisible to that section of the population who is social distancing safely at home. So let's look at kind of each of these categories and talk about what they mean and how we can help within the context of COVID deal with some of these. So underlying health conditions. Looking at populations of African Americans in particular, we know that those groups, those communities of color, are more likely to suffer from heart disease, from asthma, from cancer, kidney disease, obesity, diabetes. Children born into Black families more than twice as likely to be told they have asthma. women are 60% more likely to have high blood pressure, 80% more likely to be diagnosed with diabetes, 2.5 times as likely to have kidney disease. All of those things are risk factors for COVID-19 deaths. So it's really not a surprise that when you look at the fatality rates for COVID and you lay them on top of a map of Brookings made an equity risk index that was based on this kind of confluence of race and poverty factors. When you overlay the fatality rates on top of that map, it looks eerily similar. I don't have like a trove of data scientists here in my basement, right? Hoping analyses like this will come out in the next couple of weeks. But the fatality rates are higher in communities of color because they're coming into this fight with these massive underlying health disparities. In Milwaukee, if you're Black, your life expectancy is 14 years shorter on average than somebody who is white in that city. And that is, it's unacceptable. And that is why in Milwaukee, half of their cases might have been Black folks, and then 81% of its deaths were in a county where only 26% of the folks are Black. These underlying health disparities are a big part of the reason that infection fatality rate is so high. Now, notice I didn't say cases. I'm less concerned about the spread of infection because we know that COVID-19 is highly infectious. We know that we are social distancing, not to not get the virus, right? Because the idea is that most everybody's going to get it over time, unfortunately. But we're social distancing to keep healthcare from being oversaturated. The corollary to that, though, is that folks that are coming into this with underlying health disparities are likely to have a much higher infection fatality rate. So we owe it to those folks in particular to keep them safe as long as possible. So that leads to the next part of this. Point number 2, where and how people live. So when you look at the environmental factors of where communities of color live, we know that because of historic partitioning of housing, the segregated neighborhoods, that even in areas where the neighborhoods aren't segregated anymore, they're still basically broken down by race. The places where communities of colors live often have high rates of asthma because they're located near toxic dump sites, because they have more people crammed into smaller places, because they have cockroaches, that kind of thing. I remember after I worked on Legionella in New York City, we were going around talking to communities about why it didn't get taken more seriously in their communities. You know, why weren't they more focused on doing testing for this disease when we did, press releases, all that kind of stuff. And what they said was, my kid is living in an apartment where the pipes are covered with mold and that's giving him asthma. How can I pay attention to something else when that is what's happening to me? So when you look at that, communities of color, much more likely to own homes, and they're much more likely to live intergenerationally, which means you're going to have grandparents, parents, and kids all together and in one apartment. It's nearly impossible to socially distance yourself in those conditions. That means you're going to have more spread within families. So we've got 2 of our 4 factors. We know that there are underlying health disparities that are going to increase the infection fatality rates. And we know that because of where and how these folks are living, they're more likely to get the disease too. So let's go to point 3, working conditions. So communities of color have focused on a lot of service industries and jobs to help them move up into the middle class. That's what the data shows. Those, coincidentally or not, are the same jobs that now are counted as essential. These are the same folks that have to go to work every day. They have to be on public transportation. They're still delivering food. They're at the grocery store. They're home health aides. They're being aides to nurses and doctors. They're cleaning up these rooms. They're doing janitorial services. So, okay, that's 3 factors. We know that these communities of color are more likely to die from the disease because of underlying health disparities. They're more likely to contract the disease and spread it within families because of living conditions. And we know that they are precisely the workers who aren't able to stop working. So that's terrifying. So let's add on our 4th condition here, which is healthcare. So Black folks in particular, but other communities of color in the United States, uh, communities that we're most worried about often live in southern states that haven't expanded Medicaid. They're much more likely to be uninsured. Uh, a lot of the hospitals in these poor rural areas that track with the poverty we were looking at don't have as many resources. They don't have as many beds. And because they're coming in with underlying health disparities, they're much more likely to be rationed for care. That is, if you're choosing who goes on a ventilator and one person has an underlying kidney condition and the other one doesn't, the guidance to doctors is you choose the healthier person. And what that does is it increases the bias against communities of color. So let's look at all four of these factors put together. Communities of color, particularly Black folks in this country, are A, more likely to die from COVID-19 because they have underlying health disparities. They are B, more likely to spread COVID within their families because of the environmental conditions that they live in. C, they're more likely to get COVID from the outside because they're doing essential jobs that they can't stop doing. And D, they're more likely to get poor health care when they get it because they're in areas that don't have as good health care or they're uninsured and they're having to rely on overloaded sort of public hospital and healthcare systems. So what we've done as a society is we have created a sort of like a death trap for these communities because they're the people that can't social distance and they're the people most likely to die. So what does that mean for reopening? I've got a question in the chat about why we're shut in so long. So the thing about it is, when you have communities who are more likely to die than other communities, you have to socially distance in order to protect everybody, right? That's why you're doing it. So all this pressure from reopening is coming from people who are worried economically about what's going to happen. Because of this sort of underlying conditions of what I'm talking about, which are spread across all communities of color, these conditions mean that when you reopen, those communities are going to bear the brunt of it. And the problem is that what we're seeing happen over the last few weeks as the virus has kind of crested and gone into more wider sort of suburban areas, which is what the press coverage has seen, is that tragedy, the tragedy that's happening in communities of color, is getting less and less visible, right? Because of this sort of general infection rate that's there. So here's what I'm worried about. What I'm worried about is when you begin to reopen, okay, when you begin to let people go back to their jobs, the people that are going to feel the most pressure there, that are going to feel the most pressure to go back in and to start working because their unemployment benefits are going to run out because their job is available, right? That are going to feel that fear and pressure to go back to work are the same people that are going to spread the disease most because of the living conditions we talked about, and the ones that are most likely to die, and that are least likely to be visible to the elites that are kind of running the state or the county. So my fear is that what will happen is you will continue to see an overall rate of infection drop because the rate of infection has been so biased towards like New York and LA, right? If you look at the county, we're going to start trucking down. But that overall downward trend is going to disguise these explosive fatal outbreaks that will happen in communities of color where the essential workers are that are sort of supplying the sort of raw bodies the system needs to get capitalism going. That is the tragedy that I'm worried about. So what can you do about it? And as you're listening to me, feel free to pop other questions into the chat. What do you do about it? Well, first, the first thing that you have to do, and there's no way to do this, so I'm being a little facetious, is you have to reboot the system, right? It is clear that we have created, through the choices we have made from a policy perspective since before the Civil War, we have created a death trap for communities of color where they have to keep working and send themselves to die in order to do that. That is completely, it's unethical. It's like evil. Like the deeper I got into this data, the more evil I could feel this was. Again, I'm like a new kid to this party, right? This is scholarship that's been going on a long time, but like the amount of like rage and sadness I have because of the evilness of this system that doesn't require anybody to be like a racist oaf, shouting slurs at a dinner party. It just relies on everybody pretending that nothing's really happening. And as a result of that, people are going to die, and they're going to die in the next few weeks because of that. So what can we do? Okay. So what states and municipalities need to do now going into this pattern is they need to make sure that they are over-resourcing these communities to the extent that they have been under-resourced in the past. So states right now are trying to build up testing, build up contact tracing, build out healthcare beds. They're trying to make sure that they have supportive ways to isolate people, whether that's in a hotel or in something like that. Those plans can't be equal across every county in the state. You have to look at the least resourced counties, and you have to make sure they have more testing, more contact tracers, more resources, because that's where your fatalities are going to be. And that's where you need to do the most work to keep an outbreak locked down. That's how you change the course of all this. And, when I talk about that, sometimes people will say, well, that's not a fair distribution of resources. But the simple fact of it is that's what hospitals are doing, right? Hospitals are not treating everyone with COVID-19 equally. They are treating the worst cases the most, right? The worst cases are getting the most resources in hospitals. And that's all I'm saying. The communities that are likely to get hit the worst deserve the most resources coming into this system. The other big thing is the economic benefits that have been coming out from the government are really based on unemployment benefits right now, and sort of jamming more money through established systems. And what that's doing is it's creating this massive pressure for everybody to go back to work. What other countries have done is just rerouted money through employers, so employers keep paying wages, which removes that incentive to turn all the lights back on. Right? That's a much more rational way of doing this that would be much more equitable for all of these folks. So that is the end of my rant about that. So pop questions in the chat if you want. I, again, have read so much good stuff on this. I know there's so much discussion about it. I just feel this sort of deep rage about it. And here's why. So I'm from Georgia, and I lived in 2 counties in Georgia. And where I was born, well, let me flip it around. I went to high school in Gwinnett County, Georgia, which is near Atlanta. It's a wealthier suburban county. It's had about 1,300 cases there, 46 deaths, which gives it a case fatality rate of like 3%. And again, these case fatality rates are all ridiculous because it all is based on how much testing there is out there in the world. But still, 3% case fatality rate. I was born in Mitchell County, Georgia, much poorer county, much higher percentage of people of color, especially Black folks in that county. They've had 22,000 cases and 290 deaths. Which gives them, 290 cases, 24 deaths, which gives them a case fatality rate of 8%. And that's the discrepancy that I am so worried about, which is that we are going to see lower fatality rates in these kind of wider, more suburban counties that don't have the underlying health disparities, that don't have the underlying deficits in healthcare infrastructure. And the places where race and poverty intersect, we're going to see much higher fatality rates. And that because they're not overall in general for a state, it's going to be ignored in the media. That's what I'm worried about. Whew, okay. That's what I got. Now I can basically just sit and drink on Facebook Live. So if you have any questions, feel free to pop them in there. If you don't, I'll give it a minute. I'll go back to why question I'm getting from Periscope about why are we shut in so long. So the issue here is what we're hitting right now is a plateau in cases, but there are still significant numbers of cases and they're growing in different places. So even in a place where case numbers are declining, if you open the doors right now, it's like the virus is like simmering there. It's like at a low boil. You throw the doors open. It's like you turn the fire up and suddenly you get cases of virus all over the place. That's the thing is. So you have to stay socially distant until the cases of the virus really go away, or you really have more minimal numbers of them to keep them from exploding. So one thing that's happening that I'm noting Brianna's question in Georgia is that the idea is that the governor is opening businesses typically owned by Black people with Black patrons because of this focus on hair salons and barbershops and all that kind of stuff. There was a profile in, I think it was the Decatur-ish, right, that was talking about this as like Kemp's reelection strategy, right? By reopening these businesses that were minority owned, he could sort of target those populations. To me, and I have no idea. I mean, good, who the hell knows what's going on in Kemp's head. But I will say that the thing about structural racism, to me, trying to learn it and study it, that is so disquieting, is that you don't need anybody to do something racist for it to have a deeply discriminatory, biased outcome. You don't need like a cabal of like racist Kemp supporters in the Georgia Capitol who are all kind of scheming to target specific communities. Now that may be there. I mean, God knows what the hell is happening, but you don't need that because the structures are so powerful that connect race and poverty. So one thing that I'm getting from Periscope is whether Kemp is taking orders. I think that it is so interesting that even Trump shot Kemp down, right? And the reason for that is if you look at the president's plan for this, right, the 6 pages of bullet points, right, essentially that it is, it does sort of say that at least you need 2 solid weeks of declining case counts, and then you could reopen businesses like gyms. Basically, what Georgia is following is sort of what in the federal plan is the phase 1 rollout. And that phase 1 rollout is then followed by another 2 weeks. If you keep seeing declining case counts, then you could reopen schools. You keep seeing declining case counts, then you could let people start coming back to work. And Georgia just didn't follow that. Like they are not following a steep decline in case counts, which means that what I was saying before about simmering, the cases in Georgia aren't even really at a low simmer at this point. They're still at kind of a steady boil, and especially in some counties, they've still seen some increases. So what I'm worried about is not a statewide decrease, but is every community in that state continuously decreasing? Then you can start talking about your gating criteria. All right. Yep. So I think one thing that's getting lifted up on Periscope is, this could be payback for the amount of hatred towards Kemp from the Black community. And, I think that one of the problems from a public health perspective, because I'm putting on my emergency public health hat, not even so much my guy from Georgia hat, is that because the politics in the United States are like so racialized, right? Especially in southern states like Georgia, but in New York City too, for God's sakes, we're the most segregated city in America, where I live now. It becomes really hard to separate the fact from the politics. This policy is going to hurt people of color across Georgia. It is going to hurt them. It is going to cause more fatalities in that community. It is going to cause more economic damage. To me, that's actually worse if Kemp isn't trying to do that. If Kemp is so unaware that he is doing something racist, and the outcome of that is that racist, that is the scariest thing to me, because it means that forgetting, right, that training that you have as like kind of like White Boy in Georgia, right? You get this training not to see racism. That training is so good, right? That they don't even realize they're being racist. That's the scariest part. That's to me even scarier than somebody who is trying to do this with like hatred, if that makes sense. Because that means the structures are so powerful, we are so caught in them that they're going to keep doing harm, damaging harm all the time, even if you don't have bad intentions. It doesn't even require bad intentions. All right. And I think, one thing that Andrea's bringing up is the idea that COVID is revealing everything that's been there for years, but is being magnified. And that's right. One thing that we study and we talk about in disasters is that a disaster is something, it's kind of like a heart attack, right? You think the problem is the heart attack because when it happens, that causes the harm. But you're having that heart attack because of years of behavior, right? Because of like cholesterol buildup. Same way, when a pandemic hits, what it does is it is a revelation about all of the underlying inequities that were there. So because the pandemic came, it is going to kill along these structural lines that were baked into the system beforehand. So yeah, it suddenly does make it visible what a death trap that has been created by all of these structures and policies. That's right. So it's a revelation. The question becomes, what do we do with that revelation? How do we use the energy of that revelation to build a more fair, more just society? Other question I'm getting is about unemployment benefits. If people don't go back to work, they could lose their benefits. So this is actually something that I've been trying to track down. I even called in a favor from my friend Grant, who works for Georgia Public Broadcasting. And what I've gotten actually is this hasn't been decided yet. So this policy is being rolled out, but the Georgia Department of Labor hasn't settled on a specific policy for unemployment benefits because of this critique. So this is an area where pressure is changing it. They are saying that they're going to allow people to get unemployment benefits even if their job is open for exactly this reason. I don't know how it's going to turn out. So getting a question, so many of the people who are coming into the hospital, right. So we aren't testing so many of the people who are coming into the hospital. So I don't think the numbers are even close. Also, I got here late, but the Hispanic population is being affected more in my experience in the hospital. So two things on that. One thing is, the testing numbers are ridiculous. The real analysis we need to do is to look at sort of death rates in a community and average over the last few years, and then look at sort of the excess or extra deaths caused by influenza-like illness during this time, right? Because we're not going to test everybody. The tests are ridiculous. Some people aren't getting tested that can be. But some cities and areas are starting to look at this excess death number. So the more we can look at that, the better picture we're going to have of how many people are actually getting this and are dying from it than any testing rates, because testing rates have been so low. And this was lifted up earlier too. We're not just talking about Black populations. We are in particular trying to talk about people of color, communities of color, and how they are connected with poverty, which is generally worse in the Black community than other communities of color. But in particular, Hispanic populations in the Bronx, is one area in Texas, Florida, those areas where you have Latinx populations, especially where they overlay with poverty, you're seeing the same issues. And the reason is because you have the same, I'll go back to my 4 factors that I was doing at the beginning. You have underlying health disparities that are caused by structural racism in the community. You have people who are living in places that cause asthma because they're near toxic waste sites or because they have cockroaches or air quality issues, and they're usually crammed. Multi-generations are crammed into an apartment, which means that they can't social distance. You have communities of color who are trying to grab onto jobs that'll get them to the middle class, which are the same jobs that are now being called essential, which means they can't stop working and stay home where it's safe. And they have worse healthcare because they tend to have lower rates of insurance and their hospitals are worse. I'm not speaking about yours in particular, Heather. I'm just saying in general, that's what the stats show. And so basically you're creating this situation where the group of folks who are most likely to die are the group of folks who are likely to spread it to their families and they're likely to get it because they can't stop working. And when they get it, their healthcare is going to be worse on average. So you're creating through these structures like a death trap, which means that these people and the backs of the reopening plans are landing on these people. These are the same folks that are going to go out and have to work to get capitalism going, and they're the ones who are most likely to die. So it's this evil catch-22 that are caught here. So so DeKalb County, 35% infection growth rate over a 10-day period. That's right. And this is the thing that state numbers are disguising this, right? If you look at the state or if you look at the country, you could say that we are plateauing. But the way epidemics actually work is you get explosive outbreaks in one place and then those exponentially filter out. So if your state is declining, but you have an explosive outbreak in DeKalb, right, that can trigger an outbreak in other places. All right. So I'm missing this one. I don't quite understand this one. The only reason I believe they're saying more blacks is because they aren't getting infected as much as whites at 50%. So I'm missing that one. Clarify it for me. But I do think what happens is infections work by connections, right? So you're likely to get infections within a community, and communities are racially segregated. So that means we're going to see times when we see explosive outbreaks in communities of color, and we're going to see explosive outbreaks in white communities, right? But the trick is the ones in communities of color are going to kill more people, and that is going to be less visible to the white communities. That's the problem. That's the underlying structural problem that we're talking about. So what I would say, so getting a question about would I not open states yet? How would I manage? So the problem here, like the big picture problem, is that the way we're choosing to manage this is by routing more money to small businesses and to unemployment. But the small business money hasn't been enough. And a lot of large companies have kind of bogarted money off the top of that. And so people are mostly relying on unemployment benefits, which is creating this incredible pressure to reopen. The pressure, I don't think, is mostly from people who want to go to the movies or want to go to restaurants. The pressure is from people worry that all these businesses will fail. In every other country, or in a lot of other countries, in Ireland and Canada and New Zealand and most of Europe, what they're doing is they're funneling the recovery money more intensively to businesses to pay workers. They are saying to every business, look, we're going to funnel the money through you so you keep your workers on there during the social distancing. We've created this incentive for people to fire their workers so they can get unemployment. So what do you need to do? First, the thing is that, just to answer Ashley's question, this thing where we're focusing on gating criteria, this thing where we're looking for the number of cases to go down, and this, and then every time the cases go down, we let ourselves go free a little more. It's not really the problem. What we need to make sure we do from a public health standpoint is stand up more testing, the ability to contact trace, the ability to rapidly isolate contacts of people who are sick. Once we build those muscles up, that is really when it's safer to reopen. Because when you're just letting people go free into the world, right, because you have fewer cases, any one case is still going to cause exponential growth. So all you're going to do is you're going to shut yourself down again in a few weeks or a couple of months. So you've really got to focus on building out that musculature. And as you build that musculature out, then you can sort of walk through this gating criteria. I mean, if I were going to spitball, I would say the way the American plan, President Trump plan is, it's in 2-week chunks, right? It's like 2 weeks, and then you can go in 2 weeks and 2 weeks. You would need it to be a period of something like 4 weeks. You would need to say you had declining case counts in every county across your state for a period of something like 4 weeks, go through 2 incubation periods. Then you can sort of go into a few businesses reopened, see if you keep going down in all your areas, then you open a few more. And you would want to do it by priority rather than by sort of business type, right? Stand up. This is what New York State is doing. Look at the businesses that are most essential to getting the state running, open those first, and then go. So you want to stretch it out more and really focus on building capability instead of just reopening. Because if you reopen, you're going to cause a spike and you're going to close down again. All right. Question from Brian. What is my current projection for case numbers giving decreased restrictions? So I don't know that I can do that math in my head. What I think is, so the premise of what I'm talking about today is that the spikes that we're going to see is that we're going to see spikes in particularly in communities of color first. So one benefit actually to Kemp opening now is that you could see the overall case numbers for the next 2 to 4 weeks continue to decline. What I care about most is fatalities. I want to make sure that we don't see more fatalities as case numbers decline, because what my worry is that case numbers will actually continue to decline, but because the people that are keeping the economies running are mostly communities of color, they're the ones who are going to go out in harm's way again, and they are also most susceptible to dying from COVID because of underlying health disparities. You're going to see fatal outbreaks flaring up in those communities instead of the milder outbreaks that we're seeing in other communities. That's my worry. It's less about case count, more about actual bloody death. It's hard. I don't know enough about Georgia modeling to represent a number. I think that the other thing is that this kind of spike will take 3 weeks, 4 weeks. So 2 weeks from now, people will be declaring this a success. And that may cause other states to open up because the incubation period is longer. So we've really got to see we've got to go through a couple of incubation periods, a couple of 2-week periods before we see what the issue is. So let's see. So no, I don't think the answer is, because I was answering Ashley's question before, I don't think the answer is to continue isolation forever. What I think, though, is 2 things. I think, one, we still have time to change the way we are giving benefits to folks, so we're not causing this big tension with business owners. And second, that you could build up this contact tracing isolation muscle in a state pretty fast. So Vermont and Massachusetts have hired tens of thousands of contact tracers. You're putting that army in place. For me as a public health person, I really care less about how many cases you've got and more about have your tests ramped up? Do you have contact tracers in place? So like 3 weeks from now, if we've been able to double the amount of tests, triple the amount of tests we can do, triple the amount of contact tracers we have a lot of spaces to isolate people voluntarily so they don't spread the disease, that's what's going to make me more comfortable, not sort of declining cases in each places. So I'm just saying, focus your emergency management muscles on building that army. That's what's going to help you when this thing pops back. So to Heather's question, the numbers are calculated on deaths from flu-like illness, not positive tests. No, actually, the numbers I'm giving are based on tests because that's the only data we've gotten. What I know, though, is because I just know some of the people doing it, what each of these cities are doing, Milwaukee, Chicago, are going back and they are looking at their death rates over the last month. And they're saying, okay, here's what we tested. Here's what we thought our fatality rate was, but it's actually here. So like New York City added an extra 1,300 deaths to its count when they went and did that. And other cities are going to do that too. And when you do that, these fatality rates in communities of color are going to go up. It's going to get worse. Oh, look, this is like an easy question. I love this. This is much better than the math question. So what is a contact tracer? So here's the way this works. Here's the way to stop this. And the great thing is it doesn't actually rely on new technology for tests or new innovations or things like that. It relies on people. Because when a person gets sick with COVID, if you can do one test, what's most important is to be able to trace all of the contacts that person has. That's where a contact tracer comes into play. So a contact tracer is a person that interviews the patient, figures out all the people they've been in contact with. Usually it's like 40, 45, 50 people. Then they contact all of those folks and they make sure that those folks are isolating themselves. They're doing temperature checks twice a day and that they don't come in contact with anybody else. Now, the thing about a good contact tracer is when you find those folks, you have to make sure that they are really isolating themselves. A lot of other countries have set up places like hotels or camps. Some places like China have made contacts go into camps. They've said, look, if you walked by a person with COVID, we are locking you up for 3 weeks. We don't have to go that far, but voluntarily, if I was exposed, I would probably want to get away from my family, right, for a while. And I get a lot of rest too. That's always good. But the main thing is you can create spaces that people can go into to keep themselves safe. So that's what a contact tracer is. They're a person that connects, talks to all the contacts that a sick person has come in contact with. They give them advice. They help them isolate. They often check their temperatures to make sure they're not getting sick. And by building an army of those folks, we can make sure that we track the contacts and that we isolate people strictly. And that is the number one most important thing to do to conquer this virus. It is not like movie theaters and bars and whether we reopen nail salons. It's not even testing. It is, can we trace the contacts of people who are sick and then isolate them to keep them from getting other people sick? Because the way exponential growth works, even if you have 10 people spread apart in a restaurant, you cause a little outbreak, that outbreak will grow so fast. But if you can lock it down, then you're going to be able to beat the virus in the long term. So 2 things. Andrea is saying, how could Georgia initiate contact tracing like Massachusetts's Community Tracing Collaborative? I love that, by the way. I think that's a great program in Massachusetts. Vermont is doing another one too. A lot of health departments are looking at this. The key is that it usually takes an influx of public money because you've got to fund people to be contact tracers. Now, I mean, not luckily because it's terrible, but we have a lot of unemployed people in the country right now, right? There are a lot of people looking for jobs. It's a great time to start a paid volunteer program, something like a Peace Corps kind of program in AmeriCorps, where you're paying people to be contact tracers. Tom Frieden, the former head of the CDC, said we needed 300,000 of them around the country. That's not out of the question if states like Georgia and Florida jump in and build those armies. How could you isolate people in their communities? Some people have had really good success with voluntary isolation. Like I was saying, if I had somebody in my family get sick, there are 6 folks that live in my house. I don't know how to isolate people in my house. But if there was a safe place that was a good place, like a hotel or like a good quality summer camp that we could voluntarily go into, not that you would make them do it, but if families could have that choice, I think by giving them the choice, you could increase the way isolation works. One thing states are doing, Ashley's asking a question about testing. We're testing, but those only for people that want to get tested. Here's what New York did. California did this too. I think New York's methodology was better. They did a survey of 3,000 folks. They just went out, they knocked on their doors, did a random sampling, tested them for COVID. And by doing that, you can figure out what percentage of folks affected you have. So in New York City, 21% of the people that were tested had been exposed to COVID. They had COVID already, which is an astounding number. That means, for one thing, that we have a better estimate of the case fatality rate. The real case fatality rate for COVID is probably around 1% of the people that's infected, because this is the best random data we've got. Once states can put in place random testing like this, not testing based on choice, not even testing of really sick people, just random testing in the population, that's when you can get a good sample of how many folks have had COVID. Now, the good thing is, because of statistical sampling, New York State, right, which has 25 million people, only needed to do 3,000 tests. So to me, this is a really good use of limited testing resources because it gives you so much information from an emergency management standpoint. Whew, okay. I feel like I've successfully chewed through 45 minutes. I haven't finished my whiskey because Um, uh, because I've been answering so many questions. Good question from Brian. So is this serology testing? So, okay, there are two major kinds of testing for this virus. Most sick people are getting an RNA test, a rapid kind of DNA test to say, are you sick right now? It just shows whether there's virus in the bloodstream. But then on the other side, you've got serology testing. When you're doing serology testing, you're testing blood for antibodies. And what that is showing you is, has your body tried to fight off this infection? So you might not have it now, but you're testing for somebody to see if they had the virus 2 or 3 weeks ago. So you can see who in a population did it. So to Brian's question, yeah, the New York State survey was based on serology testing. Now, the thing about it is serology testing right now is only 93% effective, 95% effective, which is like a high rate of false positives for if you're actually for one individual person. But if you're doing it for statistical sampling, you can kind of measure that out. So it's still useful for these population surveys. But like, we couldn't give somebody a certificate. So people have heard in the news, oh, I'll get a certificate because I've got antibodies and then I can go back to work. The serology testing isn't good enough for that yet because there are too many false positives, but we can use it for these big scale population surveys. Is there any data on people of color and vaccine uptake? So yeah, it's not great. Communities of color have a low trust in government, which is not a surprise, right? Considering the pain they've suffered at the hands of government over the years. But one thing about that is that because of famous things like the Tuskegee experiments and other debacles like that, communities of color are less likely to do vaccines, right? Because they think that vaccines could be filled with poison, which they have in the past been that way, right? I even got a question on this in the chat a little bit ago from Who is Like God. That's actually, interestingly, that's what my name means too. But this isn't my handle, which would be quite a feat actually if I could be commenting while I was live streaming. But people think that the government puts out vaccines that will like sterilize them. And the reason is that actually happened in history. One of the things, the outcomes of the earliest part of the 20th century is there were vaccine efforts that actually were forced sterilization efforts. So that's a real thing that has happened, and it has caused real fear. Wow. I triggered Siri there, and Brianna, Siri is trying to answer your question for me. I'm hoping it stops soon because I can't hear anything. So anyway, okay, still talking at me, so I'm going to try and ignore it. So one thing about uh, can you hear Siri? Just let me know. Siri's like talking. Siri's like giving my whole rant back to my ears. So okay, Siri's done now. Oh, except I just said Siri's name. Okay, so anyway, the answer is when there is a COVID vaccine, there probably will be a lower uptake in communities of color, which is unfortunate because I just spent 45 minutes talking about why the fatality rates in communities of color are going to be higher. So that's a real mismatch. So that's something that we need to start right now working on, building that confidence. And that will have to be done through the communities of color, themselves working with community reps. Nobody's going to buy that from the politicians who are running states because you just don't have that buy-in because of this historic lack of trust. Thanks. I'm glad everybody jumped in to say they couldn't hear Siri. I'll bring on Siri as a co-host. So Ashley's asking, do I feel confident in the Trump administration? No, I don't. I mean, I don't even know how to sugarcoat this because I feel that Tony Fauci, Deborah Birx are strong public health folks, but we do not have a coherent strategy from the administration. We have states fighting with the federal government for supplies. As an emergency manager, I'm actually really curious about this on the inside because there's an emergency management assistance compact, which is about how states partner together and they can do resources across state lines, and the federal government can have like a supportive role in that. It seems to me right now that the way the disaster medical system is doing is massively chaotic and convoluted, and it is hurting states that need it most because of priority systems that don't make any sense. And I'm leaving aside all the kind of gaffes at press conferences and all this stuff about disinfectant or whatever. Even looking at the policies themselves, right? We're looking at policies that are not competent from a public health standpoint. They just aren't rational. In the public health world, there are 4 or 5 different theories of the case about how we can respond to this. They're all valid. They all have data. The federal government is not using any of them. They're using just some weird hybrid of shit like superstition and infomercials. It's sort of crazy. Woo. If I were governor, how would I reopen a state such as Florida? The contact tracing question was easier than that. I will give you here's the Mitch plan. Okay. We're a little late for the Mitch plan right now because I think it is hard to go into reopening unless you switch some of the economic incentives that are happening already. You have to switch the way that the relief is going out to give you a path to reopening. So, and I feel like I'm repeating some of what I said before. I think that what I would do is, first I would set thresholds that were community-based, not state-based. So I would be looking across the state to monitor gating criteria or like caseloads in specific communities. Now, to do that effectively, first I have to do statistical population sampling across the state. Like none of the gating criteria released by any state or the country makes sense because there's not enough testing capacity right now to actually know if the number of cases is going down. We don't actually know that. All we know is that the number of hospital beds are going down, maybe the number of fatalities are going down. So if you didn't have testing, your first gating criteria would be, are my hospitals empty of COVID patients? Not are the number of COVID patients declining, because if there are still hospitalized COVID patients and we have a case fatality of 1%, that means 80%, 85% of your patients are out there already. So until your hospitals are empty of COVID patients, you can't be sure you don't have just thousands of patients around there in the world waiting to cause more fatalities as soon as you open. So that would be the first thing, is that your initial gate, if you don't have good testing, has to be based on hospitalizations, basically almost dropping to zero, then building up your army of contact tracers, and then you can move into a 3 to 4 week gating phased opening period, something like that. All right, I'll think about that one for next time. I'm moving towards closing this out. I think I'll think about sort of Mitch's plan to reopen and sort of try and put some more stuff together from that. Because a lot of people are saying good things in a lot of places. How do we like pool tests into one place to save testing capacity, all that kind of stuff. But I would rather go and have the rest of a Saturday night. So I'm just going to say for a second, any last questions anybody wants to sort of check in with me about? Going once. I'm going to take a leisurely sip of scotch here while that happens, because I know there's like a time delay. Okay. Well, thanks so much for checking in. I hope you guys are safe. If you have questions, feel free to lift in towards me. You know what? It's not. I didn't say bourbon, Ashley. This is actually scotch. I'm usually a bourbon drinker, but I moved into Bowmore because the Scotch are depressed people, and that's just basically how I'm feeling. So I'm just sort of rolling with that. Thanks so much. We'll be talking soon. Hope everybody stays safe and take care out there.